Okay, so let's look at our disaster planning concept map. Okay, and so these are kind of, I don't know, I must have scanned them backwards. Okay. So here's the thing I want you guys to understand the difference between, because I think when you start studying this, like you start thinking about it as all kind of lumped together. But when we talk about, like, there's different categories. So there's blast injury, there's chemical weapons, there's nuclear radiation, and then there's biological agents. So make sure you know the difference when you're answering a question on the exam, or you're thinking about what it is. If you're thinking about a nuclear radiation, if you're thinking about a chemical weapon, a biological weapon, all of those things make a difference. Because when we talk about breaking them into categories, like category A, and if you guys look here, see how I have anthrax, smallpox, Ebola, all these, they're category A because they're the ones that have the highest morbidity and mortality rate. So those are the ones we're talking about most, but they're biological agents. If I come down here and I talk about like chemical weapons, we're talking about a blood or cyanide agent or vesicant. Those are completely different, right? So it's a completely different agent. It's not a biological agent. Okay, so just make sure you're able to categorize them differently. That's why I separate them out on the concept map, so you can see that they're a different type of agent or reagent. Okay. No. Yeah, just the biological agents. Yeah, just the biological agents. Okay, so then, there's two ways we look at this. We look at how do we treat the situation? How do we approach the situation when we're working like in a disaster situation? And then once we've identified what the disaster is, whether it be a biological agent, a chemical agent, nuclear warfare, or something like that, then how do we take care of those patients? So don't forget, like when we look at this, and this is really like, I think it's, we talk about all the things that we've learned, because we've talked about all the devastations from COVID, but let's talk about all the things that we've learned. You guys have actually kind of lived through this in some sense, right? So mitigation or prevention. Okay, so increasing surveillance and security. Look for the highest risk population. What's our highest risk population for COVID? Obese. So they said elderly and obese, right? So here's one for smokers. If you're a smoker, good for you. Usually everyone's like, smoking, right? No, I'm kidding. Don't smoke. I don't need anyone to publish that on YouTube that, like, she said good for smokers. So yes, but we didn't know that at first. So looking for the highest risk population, and then looking at public health. Immunity is in immunizations is standard across the book, is the highest likelihood of preventing disease. Okay. Preparedness. Okay, this is mandated by our joint commission, right? So we have state, national, and local mandations. All healthcare organizations have some kind of mandate as far as how they're supposed to take care of these disasters. There's a communication protocol. We must prepare. This is why they do those disaster drills. Have you guys been a part of that or been asked to be part of it? Our students used to always do it before COVID, and then they kind of held off a little bit on the disaster drills, but they would actually have students go over and act as patients and be part of this preparedness where we would do disaster drills. And this actually began after that, the Pulse nightclub, the situation I was telling you about. They said, why do we have to be reactive? Why can't we be proactive? And I think I might've been telling you guys before, or maybe it was my clinical group, that they actually went out to Nevada or Vegas or wherever and educated the healthcare systems there. And not long after was like there was a shooting at a concert or something, like Jason Aldean or something like that. And they were like, oh my gosh, those hospitals were so prepared because they had just been trained in triaging and taking care of these situations. So disaster drills, we do those. Response, okay, so we talk about FEMA, Center for Disease Control, public health centers. If it's a federal emergency, this means that we've activated the national response, okay? If it's federal, just like federal, if you file your taxes, it's a federal thing that comes from the federal government. It's a nationwide thing. We've activated our national resources, okay? And then recovery begins when the danger is gone, okay? And it lasts until the community is restored. And then this is when we see our post-traumatic stress disorders, okay? There's a life safety code, which is published by the National Fire Protective Association. QSIN, we think about that as nurses. You guys see us put them in our PowerPoints, quality and education and research by nurses. And then fire drills, response, all that stuff is done yearly. Okay. And then hazmat. So like, how do we decontaminate? How do we know how the toxic agent is absorbed? Do we have an outdoor decontamination area? And then here's just some things that, you know, we've had historically, like tsunamis, terrorist attacks, pandemics, Hurricane Katrina, earthquakes, you know, all of those things have been some things that we've had to have a national response to. Okay. So when we talk about disaster preparedness, okay, if it's a multi-casualty, smaller hospital, local resources, but if it's a mass casualty, this means that the local community is overwhelmed and multiple healthcare agencies need to help. Okay. So, you know, I think about a small community like McDonald. I live in McDonald. It's a mile by a mile, right? I don't even know, maybe 300 people over there. It's something really small. So if there was a mass fire in McDonald, they would probably not be able to handle it locally. It's so small. They have one little fire department with 2 little fire trucks. They would need Wethersfield and Niles and Girard. So they're already looking outside of their territory. So when you guys move on to your bachelor's, you will learn about studying communities, because that is a big part of what nurses do as far as like being able. So looking outside is a mass casualty. We treat on the likelihood of survival. Okay. So we talked about this in the case study already. Here's red is life-threatening. They're a quick save though. So they have a sucking chest wound, open long bone fracture. And that's why we were saying that, Nicole, and I was mentioning it too, because I think of like long bone fracture, open, meaning it's outside of the skin, tension pneumothorax. I'll remember tension pneumo. What do? Put a 14 gauge needle in there, let the air out, right? Until we can get the chest tube in. 2nd or 3rd degree burns, but on less than 40% of the total body surface area, right? Because now they would require so much if it's more than 40%, right? Look at all the IV fluid you'd have to give and the IVs you'd have to give and how you'd have to keep the patient warm and all the stuff that Mrs. Phillips just talked about, right? Yellow, they could wait for a few hours, no airway compromise. So if you get a question that talks about airway compromise, you shouldn't be thinking anything but red or black, right? If they're not breathing at all, it's black. But if it's an airway compromise that we can save, then maybe red, okay? But yellow and green should never be airway. Eye or central nervous system, as long as it's not compromising the airway or the brain. So if you have you know, maybe you lost motor strength in the left arm, but hemodynamically stable, they're breathing okay. Okay, maybe does that, you know, have to be something that has to be taken care of as long as they're not bleeding. If airway, breathing, and circulation are compromised and it's just an extremity, then they're not going to be red or black, right? Vascular complications with collateral circulation. Okay. Green, they can wait hours to days. They go from, we get them away from the area. So we get them like triaged away from the area. Maybe they need upper extremity, external fixation or external fracture. Maybe they have a behavior change. These are the walking wounded. Maybe they're really, really upset because they watched the mass casualty. They saw their loved one. You know, we need to get them out of the triage area. And then black injuries, too bad. So comfort measures are provided. So penetration to the head, high spinal cord injuries, 2nd and 3rd degree burns, greater than 60% of the total body surface area, pupils are fixed and dilated, agonal respirations, and then profound shock. You guys know what shock is, right? So we're hypotensive, tachycardic. So notification of the activation. So emergency room and EMS communicate. So then we'll say, hey, and usually the media gets it out. I didn't watch the award ceremony last night, but this morning I had 17 texts about Will Smith. And I was like, oh my God, what happened with Will Smith and Chris Rock? So I didn't even find out till I got to work what happened because I was like, I just got to get here, you know? So, so like with all the media centers we have right now, right? Sometimes like the nurse in the ER might be like, hey, listen, did you guys see that there was a big mass shooting down the street before we even get a call from EMS? Because EMS is getting to the scene before they can, you know, predict and make a comment to the emergency room. So media broadcast, why is media important? Sometimes it's good and sometimes it's bad. Yes, do not come to the hospital because now we can't get the ambulances into the hospital because everybody's flying here. So if you had a loved one that you thought was at the Pulse nightclub, please go to the Hilton hotel room because all communications to any family members at this time are going to be made there, right? So let's use our media for our resources. So media are important, media broadcasting, and then National Guard, right? So we had the National Guard come in, St. East downtown because of COVID, right? National Guard had to come in and provide resources for us. Military, In the Pulse Night Club, they had any physician that was a surgeon come downtown, any circulating nurse that could come down and work in OR, get down here, because patients were coming in. Jane Doe 1, room 1, Jane Doe 2, room 2. We had no idea what was going on, other we could tell the patient was bleeding, right? So anybody that we can utilize and resources that we can use. And then don't forget about our spiritual care, right? Even the spiritual care department is really important to help navigate the visitors, navigate the family, provide for care for the healthcare providers as well. So incident command system. So facility organization model, it's led by the hospital. So there's one incident commander, right? The incident commander determines when to stand down. There's an emergency operations center. This is the command center. This is just, so who's the head provider in triaging? So this is like the head physician that's triaging. This person goes here. This person goes here. Usually a nurse and a doctor work together, triage together. This one requires OR. This one requires a yellow station. And as we get to these mass casualties, guess what? You guys might be team yellow. You guys might be team red. You guys might be team black, and you guys might be team green. So you're looking for anybody tagged green because you have the resources on you to help team green. You guys have the resources, the morphine and the things that you could give to patients that are black. You guys have everything like 14 gauge needles and something to stabilize a long bone fracture and IV fluid and blood for patients on team red. And then I forget what you guys were we yellow? Yeah, so you guys might have splinting material for those upper extremity fractures and so there's no reason for you guys to carry around a ton of IV fluid if you're not trying to take care of patients that are in red, right? So have the right resources for the right. So that's how that triage system works. Let's see. Yes. Yeah. I am. Yeah. Yeah. So debriefing. Okay. This is what. It is creepy. Oh, I'm sorry. You have the wrong number, but you know what? Are you looking for the phone number that's the hospital? Doctor, what's his name? Woodville. Okay, this is the hospital call. You're welcome. Bye. So debrief. One of the things they said is like, now we have to look at the nurses and the healthcare providers and debrief this COVID crisis, right? I mean, you guys know when you guys were in the ICU and we were at St. Joe's and I'm sure at Boardman for 3 or 4 weeks in a row, that's all that the ICU was COVID. Everybody was intubated. We were withdrawing support from everybody. Can you imagine doing that for a couple of years? So debriefing and saying, okay, what can we do better? You always have to step back and say, what can we do better? What can we change? What can we do to help? And then the immediate and long-term effects, lifestyles can be altered for these patients. If you've lost an extremity in this tragedy, and then, I think about debriefing and they talk about there possibly being another spike in 5 weeks. How do those nurses and doctors that have been frontline for so long recover so that they're prepared to care for the next wave of COVID, should that be the case, right? Okay, so then I'm going to go back. Let's go up to biological agents next, okay? So these are the ones that we categorize like A, B, or C, right? So biological agents are categorized A, B, or C. A means there's a high death, okay? B, low death, high illness. C, low death, low illness, okay? But you could see that these are all, we're talking about A. These are people at high risk for death, right? And we talk about anthrax, right? I just had a student email me last night. She passed her boards, right? She passed her boards and she's like, oh my God. I said, how were they? She emailed me. She's like, I said, how were they? And she's like, I got 75 questions. It was cake. And I said, great. And she said that they had case study questions on there. And she knew, and she said that the case studies that we were doing were very equivalent to the case studies that she received as trial questions. And she said it was really, really good. But she shared she had like 3 mass casualty questions. And I said, and I didn't ask about what. I said, oh my gosh. And she said, yeah, she felt very prepared. So they're out there. These students are getting these kind of questions. So anthrax is a big one, right? So we have to think about skin, GI, or inhalation, right? So 3 things. Of course, inhalation is going to be the most concerning, right? If we look here at inhalation, death is almost 100%, okay? So first, they have flu-like symptoms. Second, they have stridor, shortness of breath. don't go crazy. Like thinking about if you inhale this, they have stridor shortness of breath. They can have pleural effusions, bleeding with meningitis and cerebral spinal fluid. Okay, they go into septic shock. So I think of inhalation as being a breathing circulation issue, right? So we've got in hallmark sign, this hallmark sign, widened mediastinum. I think of that. That's a huge deal when we talk about inhalation and we talk about bleeding and you know, maybe them having some effusions in the chest. Okay, have that highlighted. Skin, we have some edema, pruritus, macules, papules, ulcers, scabs, they fall off. That's not anything new, right? That's if anybody has any kind of skin lesion, right? This is why I never went into dermatology. I'm like, what the heck is that? If it's dry, make it wet. If it's wet, make it dry. I don't know, add a steroid, right? What do we do with skin? Because it gets swollen, we get scabs, we have edema, irritation, itching, right? And then GI, they have abdominal pain and ascites, not crazy, right? Nausea, vomiting, diarrhea. So does everybody that has every kind of GI disorder, but they can go into sepsis, which would be hypovolemic, right? You guys know that from hypovolemic shock already. So treatment, penicillin, erythromycins, gentamicin, and doxy. Look at this mass casualty. Put this in your mind. Put this in your mind. If we have mass casualty exposure, very often they go to Cipro and doxy. Cipro and doxy, Cipro and doxy, Cipro and doxy for mass casualty. Okay. Okay. And then your anthem is your antitoxin. It's not contagious. So standard precautions, right? You don't have to put an N95 respirator on. Standard precautions and cremation because we got to kill the spores. So after death, cremation. Okay. Smallpox, category A, extremely contagious, direct contact and droplet. So these patients require contact and airborne. Okay, this is just like our COVID patients, contact and airborne, extremely contagious. Pre-eruptive, they have flu-like symptoms. That's like any other illness you have, right? Before you get like really, really sick, don't you feel tired, exhausted, feel achy, and you're like, oh my God, am I just exhausted or am I going to get sick tomorrow, right? When you hit the eruptive stage, they have bumps or alveolars all over the hand and feet. These last the longest, especially in the oropharynx. Yes. Okay. I'll go back and look at it for you. TB should be airborne for sure. If I have that marked, do I have TB on here? Okay. Oh, okay. It does. Yeah. It doesn't. It does. Yeah. It spreads through droplet, but I always thought of smallpox as an airborne isolation. And here's the other thing that think of it as like COVID. So guess what? Do masks work? Yeah, we wear them. You know, we have evidence to prove that even just a facial masks work. But if we know that the patient actually has it, then we put them in, we wear in airborne precautions to prevent contamination of exposure. So I would note as contact airborne. Yeah. Yeah. But I think it's transmitted through droplets. So you can have it transmitted through droplets. So if they cough, it's coming out in a droplet, but that doesn't mean that it can't be inhaled airborne wise. Okay. Does it help? Okay. Antibiotics for additional infection, but remember it's a smallpox is a virus. So antibiotics aren't going to actually treat the virus, but if you have additional infection because you have skin wounds or something like that, or respiratory infection, vaccine within 3 days is helpful. They can develop a vaccine necrosum though. So you have to be careful about that. And then cremation and autoclave washing of the supplies to prevent transmission. We talk about botulinum. Okay. So GI, they can have cramping, nausea, vomiting, but inhalation obviously is worse. Okay. They'll have an elevated temperature. They can end up with that descending flaccid paralysis. So remember Guillain-Barré is ascending. This is descending. Don't forget your cranial nerve palsies. You guys know cranial nerve palsies, right? Everybody knows their cranial nerves by now, right? So know what your cranial nerve palsies would be, okay? Usually these patients are death due to airway obstruction, due to decreased tidal volume. There's no vaccine available. So airway obstruction, if the airway obstructs, can we pull in a volume, right? No, so we have a decreased tidal volume. So we have a ventilation issue. We're not able to pull the air in, okay? So treatment, we have to provide an airway. We give some fluids. We can give this equinine antitoxin, which decreases the neurosystem damage. We always should have Benadryl and Epi at the bedside if we're given this equinine antitoxin. That's a big deal. I would highlight that. Do not give aminoglycosides or clindamycin. It worsens the cranial nerve palsy. So you guys know this from studying the antimicrobials, right? Don't we have to worry about cranial nerves with aminoglycosides, especially cranial nerve 8, right? So you want to make sure that you have to think about your cranial nerve palsy. So you don't want to give aminoglycosides, which inhibit cranial nerves, with this equine antitoxin. Okay. Ebola, it's droplet and contact, no vaccine. So flu-like symptoms plus hemorrhagic shock. Okay, so these patients double glove with an N95. They need to have boot covers and impermeable gown and decrease invasive procedures. Okay, so I want you to see how I have this highlighted here. Many exposures or many patients that are exposed or a mass exposure will take doxy and Cipro. So if you think about like any type of question that you may get or a situation where they talk about mass casualty exposure, you should be thinking Cipro and doxy, Cipro and doxy. Okay. We talk about the plague, the bubonic and the pneumonic. Oh my God, this makes me think of Beauty and the Beast. Did anyone ever watch that movie? It's my favorite Disney cartoon. But they talk about her mom passing away and it was the plague and she ended up having the pneumonic plague. So you guys are like, Disney movies, are you kidding? We haven't watched a movie in 2 years. Okay, so plague, bubonic. These is tender lymph nodes. They end up septic. They go into shock and death. Flea bites, it's contagious. These are both A. Pneumonic plague, they can have chest pain, bronchospasm, cough, and dyspnea, hemoptysis, 100% mortality if no treatment within the first 24 hours. Okay. If they have a septicemia plague, they can end up gangrene in their fingers and toes. And just think about septicemia. What happens in sepsis? We vasodilate when we've got poor perfusion. So we're just not perfusing those areas. So fingers and toes. Okay. These patients' treatment, we go contact and droplet, 72 hours and until 72 hours after antibiotics are started. You could use respiratory face mask. First line treatment is gentamicin and quinolone. Second line is tetra and doxy. If it's exposed, doxy for 7 days, right? So there's your doxy again. Okay. And then lastly, we have our tularemia, standard precautions, fever, chills, headache, malaise. So don't go crazy memorizing all that stuff. All these things cause that. Think about the things that are mediastinum, right? Think about the things that poke out at you that would be very specific to one or more of those. But anorexia, fever, diaphoresis, weight loss. Okay, yeah, right. If they're nausea, vomiting, diarrhea, treatment, strepto and gentamicin, 10 to 14 days. Start within 48 hours. Mass casualty, there you go. Cipro and doxy again. Control fever and fluids. Okay. They usually die from a pneumonitis. They have an increase in sputum. They end up having hemoptysis and they go into septic shock. So you guys seeing the trend here? Septic shock, septic shock, septic shock, right? So airway, breathing, circulation. If we talk about nuclear radiation, they're exposed to some kind of radiation, and we have to be thinking time and distance, okay? So we have to shield, and this is why we talk about shielding when you guys go and take your patients to x-ray or for a CAT scan, right? We're shielding you from nuclear radiation. So external radiation exposure, no major concerns. Contamination, that means exposure, immediate treatment ASAP to prevent the uptake, okay? And then incorporation means the uptake has happened to the kidney, bones, liver, and thyroid. So think about when we intentionally radiate a thyroid, right? We look for uptake to shut down the thyroid and to stop the thyroid from working. And then we use, because the thyroid is sick, and then we use thyroid stimulating or like levothyroxine to replace that thyroid, right? So that's an intentional treatment, but it actually, that nuclear radiation actually kills the thyroid. So if we uptake radiation, it will shut down our organs. In the cases where we're using it as a treatment for thyroid, fine. But for you just taking care of patients, you have to worry about nuclear radiation. So decontamination, I always think of us triaging outside of the hospital, cover floor, strict isolation, prevent tracking of contamination. So you don't want to take that nuclear radiation and take it to the next area. This is important. We have to seal the air ducts in the vent, double bag, all labeled waste. This is why the air ducts are all sealed and our radiation areas are in different areas, because if you radiate over and over and over again, this is why most people, we want them to go to x-ray if we can. right? Because if you're going to x-ray over and over and over again, you want that nuclear, like you have to look and see how much nuclear radiation is going to be exposing the people in the hospital. Staff protection, wear resistant gowns, double glove, cap, goggles, and the dosimetry devices are really important. So those are the ones you'll see anybody that works in radiology, they wear all the time. If they work in OR, they wear them all the time, because how many times in OR do we come in and x-ray in the middle of a procedure, right? So we have to make sure, and that's why a lot of people that work in OR, they're wearing, especially in ortho, they're wearing those lead aprons the whole time. Can you imagine like those lead aprons the whole time you're doing in OR? Acute radiation exposure or acute radiation syndrome, all body systems are affected. So survival, if we look at survival, likelihood probable, we check a CBC, there's no or minimal symptoms. Possible, they have nausea and vomiting for 24 to 48 hours. They might have some leukopenia. Look at all these things they drop, right? So leukopenia, thrombocytopenia, lymphocytopenia. So your lymphocytes are going down, your platelets are going down. Okay, improbable, they have neurological symptoms now. So it suggests a lethal dose, and we have to look at survival time. Okay, so we look at shock. Here we go again. We're talking about shock. All right, so let's come down here and let's look at a blast injury and chemical weapons. So blast injury, okay, well, there's some kind of an explosion. Wasn't there just like a recent explosion like in Lebanon last year, maybe? Was it Lebanon? You guys are like, we also don't watch the news. We've been at Mercy College for 2 years. There was like I don't know if it was a chemical plant or if it was like some kind of natural eruption from a, but anyways, because I was thinking of somebody that I knew their family was over there, and I was like, oh my God, is your family okay? And they said that their family was like so many miles from it and felt felt the wave and the pressure from the blast injury. So we have to look at like what the damage is about. So I think of, so tympanic membrane, most frequent, most common cause or injury. But what happens if your tympanic membrane ruptures? Well, you probably can't hear, okay? And you might have some otorrhea. Okay, so most frequent or most common injury of a blast injury. You could have a blast lung, and that's when we have hemorrhage or barotrauma to the lung, maybe air emboli, they go into acute respiratory failure or ARDS. So this is just like an ARDS situation. We've had trauma to the lung, okay? And now we're hypoxic, of course, short of breath, of course. Maybe we have a hemo or pneumothorax because you've dropped that lung, okay? And they're hemodynamically stable. So this goes back to that surgical trauma lecture that I did in the beginning. You have a decreased return to the blood, to the cardiac silhouette, decreased cardiac output, bad gas exchange, okay? And then abdominal pain or a head injury. So we're looking for nausea, vomiting, guarding, tender. If you've ever had anybody, has anybody ever taken care of somebody that had bleeding in the abdomen? Maybe in neuro ICU, like SIC? Usually it's a rigid board-like abdomen, rigid board-like abdomen. Okay, they're very, very rigid. And then I think of head injury. You guys know that? Think of a concussion or changing their neurological status, any confusion in level of consciousness, right? And then lastly, if we talk about chemical weapons, limitation of exposure is essential with evacuation and decontamination as soon as possible, okay? And as close to the scene as possible, because if you have a chemical agent, the more you transmit that patient somewhere without decontaminating them, the more you're contaminating the other populations, right? So think about blood or cyanide, okay? So if we have a blood agent, they die from sometimes asphyxiation because it changes the hemoglobin. So the cyanide changes the hemoglobin. Well, why do they have asphyxiation? This makes me think of sickle cell, right? These patients have terrible pain and then they end up short of breath because we change the hemoglobin. Well, if I change the hemoglobin, do I have the oxygen carrying capacity? No. So I do not get the oxygen where I need it. It's asphyxiation, okay? Because we change the hemoglobin, we don't have the oxygen carrying capacity. Or bitter almonds, that's like a big thing. I think I actually had a test board question about this, about some kind of bitter almond smell with a cyanide agent. So like, I don't know. I don't know. Good question. We'll have to try to find some bitter almonds versus regular. I don't know. Smell of bitter almonds, bad almonds, I guess. I don't know. Yeah, I can smell almond like flavoring, but like to actually pick up an almond and smell it, I'm never like, oh, that's almonds. Yeah. But I mean, I use when I bake. Yeah. Okay, so respiratory failure, of course, we go into cardiac arrest because we're not transporting oxygen, right? Coma, stupor. Treatment, intubation, so we can provide the best oxygenation. We can give these nitrates, so amyl nitrate, sodium thiosulfate, sodium nitrate. This excretes the cyanide. These treatments are important, okay? We can also give high dose vitamin B12. Okay, it binds to the cyanide, so it can't be used. Very, very important treatments for blood cyanide. So high dose B12, we can give sodium nitrate, amyl nitrate, sodium thiosulfate, it excretes the cyanide. If we have another type of chemical weapon, like a vesicant, this is like a lucite, or I think of like a sulfur, like these mustards, like phosgene or nitro mustard. How do we know they have blistering and burning, respiratory failure? They can have a pseudomembrane discharge or airway obstruction. So I think of like, you know, if you have blister burning on the outside, you can go into respiratory failure because they have this airway obstruction. Think of a burn patient. She just talked about that, how they get blistering and the airway obstructs because of the skin sloughing off on the inside. It's the same type of thing with this, okay? Treatment, decontaminate, soap and water, no scrub, blot dry, right? So decontaminate with soap and water, do not scrub, blot it dry. We might have to, if we're worried about that skin sloughing off or the internal membrane of the airway sloughing off, provide an intubation so that we don't end up with an obstruction. Okay. And then eyes, copious irrigation to prevent corneal ulcers. So you see how like that's, did we talk about eyes somewhere else? Not really, not that much, right? So that's a big deal. That goes along with vesicants. We didn't talk about bitter almonds anywhere else, right? Big deal, goes along with blood. So pick out those things that are going to be very cognizant or related. Okay. Let's go to, what was the next lecture? You're going to have to, what? Antimicrobials. Okay. All right. All right, let's do antimicrobials. You know what I was thinking too, guys? Maybe on Friday, what we could do is I'll bring the concept maps back out and we'll just talk through them again. What do you guys think? Yeah, well, I'm going to do a new one on burns, but I was thinking if we kind of pulled like some of the older, start with the older stuff first and go back over respiratory. Yeah. The burns will be recorded. The other stuff, no. Good. Good. Uh-huh. Yeah. Yeah, of course. Yeah, of course. So I just, but I thought, you know, and then that might trigger a question. Like if you guys haven't like really thought about questions and you're like, I don't really have a question. If we kind of go through things again, just talk them through, then you guys might be like, oh God, I forgot. I like got confused on that concept. Can we talk that out a little bit? Sure. Okay. It'll be your time. I mean, I'm here all day, except for my 11:30 blood donation appointment. Other than that, I'm unavailable. Okay. So what are we thinking about? Well, WBCs less than 2,500 or greater than 30,000, not 3,000, sorry, 30,000 are critical, right? So less than 2,500 or greater than 30,000 are critical. So 5 to 10,000 around there is our norm. Don't forget your ESR. If you have an infection, you will have an elevated ESR. You can have an elevated ESR without having an infection, right? Think of your inflammatory conditions like autoimmune disorders, right? So those are the lab values that we look at when we're talking about, is the patient getting better? And those of you guys that have had us on clinical, how many times I'm like, what do the WBCs look like? Are they better? Or are they worse? Is what we're doing making the patient better? If not, why? Why is it not getting better, right? Why are we not trending in the right direction? So rules, culture before you start the antimicrobial, clean before you culture, right? If you somebody comes in from home and they haven't touched their wound on their leg for 4 days, we don't want that outside gunk. We want to culture underneath and see what's really going on underneath. So culture before we start antibiotics, clean before we culture, start our antibiotics, and then check our culture and sensitivity. We have to call if it's resistant or indeterminate, right? If the drug that we're giving does not help the bug that we're fighting, then we have to call, right? Don't forget about our multi-drug resistant organisms. Now, I do not want you to get this confused to clinical. So here it says MRSA, VRE, CRE, C. diff, like contact isolation, you need strict hand washing. Okay. In the hospital, C. diff, yes, strict hand washing. You'll see the big blue sticker right on the isolation sign. So we had a patient. Oh my God, who's patient? Who did we just put into isolation for VRE? Oh yeah, right. So infectious disease nurses, like, you know, health people were going to be there, and they're like, oh my gosh, we have to put this patient in isolation. They're in VRE. What do I walk right up to her and I said, do we need the blue sticker that says strict hand washing? She said, no, our hospital policy does not indicate strict hand washing only. Our antimicrobial foam stuff is fine for our VRE in the urine or whatever it was. And I was like, okay, because the literature says that VRE, we should be doing strict hand washing. So you need to look at your hospital protocol. Okay. So don't get confused on what we might have done in clinical here compared to this, because this is saying that like, it's really important for us to do hand washing with soap and water. MRSA, VRE, they occur more together. Do you guys see that right here? Occur more together. Okay. If we go here and we talk about those, MRSA, first line vancomycin. How many of you guys see vancomycin all the time? Right? We're giving it constantly. So first line for MRSA. If we're thinking of MRSA, they should avoid crowd, avoid touching surfaces. That's just good. Zyvox, if they can't have vanc. So Zyvox is second line. So anytime I see Zyvox, I'm like, does the patient have vanc, VRE, or are they allergic to vancomycin? So can they not take if I see Zyvox ordered, I think as the nurse, are they allergic to vancomycin, or do they have VRE with this MRSA? Do they have them together? Pardon? Yeah. So can they not take it? Right. Like maybe they were too sensitive to vancomycin, they couldn't take it. So we got to flip them to Zyvox. Okay. If we're thinking urine, or so I think Bactrim. Okay. Or Bactroban. Bactrim is like one. So think about when you guys talked about treating urinary tract infections. Remember ciprofloxacin and Bactrim were like first line interventions for a UTI. Well, here's why, right? So we use it a lot if we have MRSA in the urine. And then Bactroban, how many of you guys were like putting Bactroban in your patient's nares, right? So skin, I think of Bactroban for skin. VRE, so remember I said no ETOH soap, so no alcohol-based soap, but here in the hospital, you can't. Yes. Yeah. Yeah. It's the same drug. Yeah. Yes. Correct. Correct. So to decolonize, like let's say you had somebody that had, this actually happened to me. I had some kind of thing in my nose, right? I'm like, oh my gosh, I probably got an MRSA wound in my nose. So like so then I'm like picking at it. I'm like, oh my gosh, like now I'm bleeding, and so the doctor I work with, he's like, well, you should talk to yourself for MRSA. You probably have active MRSA. I'm like, okay. So sure enough, I do. And the first round treats the MRSA. The second round decolonizes. And I'm like, I don't want to be decolonized. Don't, I'm like, because I'm taking antimicrobial, and 2 seconds later, I'm going to be in the hospital, and I'm going to end up having, so yes, you can try to decolonize, but it's really hard. Those patients that are in close quarters or living, you really have to like treat the infection, but they're going to be exposed again. It just depends on the situation. Strict hand washing. If we're thinking VRE, Zyvox, but if not, we can do daptomycin or cubicin. Okay. CRE, we use Klebsiella or CRE, Klebsiella or E. coli. And then C. diff, big things with C. diff. These I would say bad poop, right? You guys know if you've taken care of somebody in C. diff, right? So no alcohol-based hand soap, strict hand washing, no antidiarrheals. You guys remember this from 122. If you take antidiarrheals, what happens? All of the infection goes into the spores. All those spores go into the diverticulum in the colon, slows everything down. The patient's diarrhea stops. We treat them with Flagyl. They think that they're better. And then once their bowels start moving, all those spores come back into the stool and they're reinfected with the C. diff. So no antidiarrheals. Okay. If they have C. diff because we're giving antimicrobials, we've wiped out all the good bacteria. Can we stop the antimicrobials? Sometimes we put them on them and then we don't stop them. Do we need to stop antimicrobials? Fecal transplant. I took care of C. diff patients all the time. I used to send them up to Cleveland for fecal transplant. So they either swallow stool, a stool pill, or swallow stool, or they actually go in for an endoscopy and they place it into the GI tract. Very, very effective. Very, very. I've had patients that I've treated over and over and over again. First line Flagyl. Here's the interesting thing. Only about 60% of patients now respond to Flagyl, even though it's first line therapy. Isn't that crazy? Look at how these bugs become multi-drug resistant. Vancomycin's got to be PO. Okay, so Flagyl, vancomycin, PO, and then maybe Zyvox. Okay. Yes, yeah, you can. Yeah. Yeah. Well, and now they've because of our infection rates, like you guys see those wipes that we're using now, they're expecting us to wash our patients more and more with those to get that bacteria off the skin. Yeah, yeah, yeah. It just takes that bacteria off the skin, so we're not introducing whatever on the skin into the patient, into their wound. Okay, so let's start about some drug classes. Okay, so let's go to tetracyclines. Okay, so there's your doxycycline, tetracycline, right? You guys know we're going to use those in mass casualty. We just talked about that. Side effects. Okay, so here's what I always want you to be thinking about when you're using antimicrobials. What does the liver do? It's a metabolism, so it's the filter. What do the kidneys do? They excrete. So most of these drugs will affect the kidney and the liver. Most of them will. So know that. Know if it affects the kidney and liver. It's going to affect one if not both. Okay. So if it causes hepatotoxicity, how do you know that it's causing hepatotoxicity? What are you looking for? Yeah, we're looking at our ALT, so like, don't make it so hard. If it causes hepatotoxicity, I'm looking for an increase in ALT and AST, right? Doxycycline, tooth discoloration, big deal. Highlight that. This is why we do not give it to children, okay? Because it causes permanent tooth discoloration. CBC, okay, no under 8 years old, no pregnancy. If they're taking this, they need backup birth control. If they're on oral contraceptives, okay, avoid dairy. Avoid dairy 1 to 2 hours before a dose. Big deal on this one. On doxycycline, avoid dairy. It says it on our Mars when we give this medication. Next, quinolones. Cipro, Levaquin, ciprofloxacin, levofloxacin, Avelox. Okay. Big deal. This is why I wrote this down. Side effect, tendon rupture. This is why we do not give it to anybody under the age of 18. Okay. Tendon rupture. Okay. Photosensitivity. Okay. Photosensitivity. I think I was telling you guys, my sister-in-law was on doxycycline, and photosensitivity is a big deal. We were this is a situation I was telling you, we were in Missouri, and it was like 40 some degrees outside. And she's like, oh my God, let's go sit outside. And I was like, aren't you on doxycycline? She said, yeah. I'm like, didn't they tell you can't be out in the sun? She goes, no, they didn't tell me that. I'm like, you can't be out in the sun. She goes, oh, just for 10 minutes. I'm like, I'm telling you, you're going to be burned. No joke. She had a ski cap on here. And I don't know, like a turtleneck, like that came up to here. She was burned from here to here, like almost 2nd degree burn, 10 minutes sitting outside. I'm like, I told you. She goes, I didn't think it was that bad. I'm like, I said, get out of the sun. So it really is. When it says photosensitivity, it is a big deal. So again, we have to think about the liver, ALT and AST, if we're talking about quinolones. Again, photosensitivity, just like doxycycline or just like the cyclines, right? Think about amiodarone. Remember when Mrs. Phillips talks about amiodarone, she said fluoroquinolones can interfere. So they prolong the QT. Well, what does amiodarone always do? Prolongs the QT. It slows down conduction, right? So that's a big deal. No under 18, you have to avoid dairy, use sunscreen. Okay, so those are very similar. That's why I put them together. Side effects are very similar. Careful with kids, careful with the sun, careful with the liver. Okay. Sulfonamides. Okay, so this is your Septra, your Bactrim. Here we go again, photosensitivity, sunscreen. They can cause blood dyscrasia. So anytime we have blood dyscrasias, we have to think about the liver, or I'm sorry, the CBC. So WBCs go down, H&H go down, platelets go down. Okay, we have to think about liver, renal. So don't forget to look at your renal function. Don't forget to look at your kidney function. Liver function, they're the same thing. Can't give it to pregnancy, breastfeeding, or infants. And of course, if they have a sulfa allergy, it's a sulfonamide. So if we're giving them, if they have a sulfa allergy, we would not give them this drug. Okay. So your beta lactams are your penicillins. Okay, that's amoxicillin, napcillin, Zosyn. Remember, Zosyn has that additive that helps it absorb better, right? So we give Zosyn all the time. It's a penicillin, but we're giving it because we give it with it's piperacillin tazo. The tazo actually helps the medication be absorbed and used better. Okay. Backup birth control if they're using it. Long term, it can cause renal or increased bunion creatinine. It can actually cause an elevated K. Obviously, that makes sense if we have renal impairment. We should avoid aminoglycosides. Okay, avoid aminoglycosides. If they are allergic to penicillin, that doesn't mean they'll be allergic to aminoglycosides. They should not take penicillin and know this, I'm telling you. They should not take aminoglycosides and penicillins at the same time. Not because of an allergy, because it changes the absorption of the medication. It changes the absorption of the medication. So very important. Okay. However, I do think it is very important to know if they have a penicillin allergy, what other medications can they not take? And carbapenems, you better know it. The C's, the Cephs and the carbs. Okay. Because how many times do we have patients that have penicillin allergies? How many of you guys had a patient that had a penicillin allergy and you still had to give a cephalosporin? Has that ever happened to you? Or did you just not check? We're like, oh my God, my professor's coming. We got to give this medication. I'm ready. I'm like, you check to see if they have a penicillin allergy. Most of the time, if they have a penicillin allergy, they still can take a carbapenem or a cephalosporin, but we need to be smarter and think about what is the allergy. If they're extremely anaphylactic allergic, then we need to see. Sometimes we'll give them a smaller dose of like a cephalosporin or a carbapenem and see how they respond to it. And if they do fine with it, then we say, okay, it's not a cross allergy, but we have to be thinking about it. Okay. Or if it's the first time you're giving the carbapenem and the cephalosporin in a small dose, you should be looking for signs of anaphylaxis, right? You should be looking for urticaria or angioedema or swelling, right? Okay. So let's talk about our medications that we have to be careful. If they have a penicillin allergy, we have to be careful if we give these medications because there could be a cross allergy. Cephalosporins, 5 generations. So Keflex is generation 2. Rocephin, we give it all the time. But generation 3. I always think of Keflex as like a lot of skin type things. Like we would give it a lot for like skin type infections, like something on the skin. Maxipine or cefepime, you guys have heard of that. We give that all the time. And then Taflaro. So the more you go down in the class, it goes from a gram positive to gram negative coverage. So the further you get down in your cephalosporins, the more. So guess what? If you're given like a Rocephin or a cefepime, it's gram positive and gram negative. Broad spectrum, we like it, right? We like it. So when we say on clinical, you giving a broad spectrum, you're like, yeah, I am giving Rocephin. Yep. I'm like, good, right? Anaphylaxis, okay? If they have an allergy to penicillin, they're going to have the same side effects, and then they can develop a colitis. Anybody take an antibiotic and feel like you're going to crap your brains out? Don't lie, we all have. Everybody put your hand up. Or it made you so sick that you're like kind of constipated. So antibiotics are hard on the GI tract, especially if you're taking them oral. So diarrhea is a big deal. We have to teach our patients about that, and constipation and nausea. Sometimes they cause a lot of nausea. Okay, let's talk about our carbs. Of the colitis for the cephalosporins? Yeah. My notes? Oh yeah, I just want you to think of colitis is a kind of a big deal with cephalosporins. They end up with like inflammation in the colon and can have diarrhea, abdominal pain. Correct. When I talk, so when we say about side effects are very similar, we're talking about anaphylactic side effects. Like most patients are going to have the urticaria, the itching, you know what I mean? The side effects that they have, if they have a penicillin allergy, the anaphylactic side effects will be the same if they have a carbapenem allergy and it's related, or a cephalosporin allergy and it's related. Mm-hmm.
So how can you say, like, is it a true allergy only if it's anaphylactic reaction?
Yeah, because I mean, you know, like what some women might say, well, I'm allergic to penicillin. Well, what happens? Well, I get a yeast infection. I get a vaginal yeast infection. Okay, that's a side effect of the drug that happens every time you take it. It's not really a reaction. That doesn't mean you can't take a penicillin. That just means, you know.
What if they break out?
We watch them, but if they don't, you know, and then we also ask how many times have they taken that medication. If this patient's like, I've had penicillin 10 times and every time I get a rash. Well, you would have had an anaphylactic reaction by now if it was true. You know what I mean? Like, because the more times you're exposed to something, if you have a true anaphylactic reaction, the worse the reaction is. So, because you have antibodies built up against it. So then you have more and more antibodies every time you're exposed. So if they're like, I've had penicillins and I get a rash every time. Okay. If your airway's not shutting down, we can treat the rash and give you some Benadryl, but you need the penicillin because, why do I want to use this big gun if I know just penicillin will work? You know what I mean? Does that help? Okay. So if we talk about carbapenems, this is doropenem and meropenem. When I worked in ICU, this was like the new drug that came out. This is the new broad spectrum. It's like it's the most broadest spectrum antibiotics. We were using it all the time in SIC for anybody that came in that was like found down in a pond and we're like, they've got a WBC of 35,000. We're like, we'd use this all the time. So you'll see doropenem, meropenem in bands. Okay. Same thing, colitis. They can have a cross allergy with penicillin. It's the broadest spectrum antimicrobial, broadest spectrum. We should be thinking about BUN, creatinine, and renal failure with your doropenems. They're pretty tough. They're strong. So let's go over to aminoglycosides because students get these all mixed up together. So aminoglycosides, okay, we should monitor the serum levels, right? So this is one of the drugs, just like vancomycin, that you should monitor a serum level on. Gentamicin or amikacin, you might have seen us use amikacin before, neomycin. A lot of times we use a lot of like neomycin for like topical things, like topical infections. So here we go. I have no penicillin. It decreases the body's ability to use the med. So see that right there? It says no penicillin, not because they're allergic to penicillin, because it decreases the body's ability to use the aminoglycoside. You got to know the difference. So if my patient needs to be on an aminoglycoside and a penicillin, can I give it to them together at the same time? No. Can I space it out? Yes. So they can take it. They just can't take it at the same time. Timing of the drug. Yeah. 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 Either one. But if the infection's really bad, I can't wait a week to start it, to start a penicillin until I finish up the aminoglycoside if I've got like some kind of double infection. So nephrotoxic, checking cranial nerve 8. Remember we talked about cranial nerve palsies with bioterrorism, right? They're not going anywhere, I promise. I'm not asking you to learn something you don't need to know. What's cranial nerve 8? I can't hear today. Can you guys? My cranial nerve 8 is busted with the sinus infection, right? Auditory, right? Can we hear? You got to be thinking about these patients have ringing in the ears or they start to lose hearing and sometimes it's permanent. So big deal. We have to talk about that. Okay. We might have to increase IV fluid with these patients to make sure that we save that renal function because renal function is a big deal with aminoglycosides. Okay. Then let's go up to macrolides. Okay. Erythromycin, azithromycin, Biaxin. What's the beauty of this drug? What's the beauty of this drug? Aminoglycosides. Or I'm sorry, not aminoglycosides, macrolides. What do we love about it? It's important. Pardon? It's usually first line for patients that can't take penicillin. So you can't take penicillin, you're getting a macrolide. So very often when patients are like, I can't take a penicillin allergy antibiotic, guess what they give them? Erythromycin. Think about, and it's safe in kids. Kids get erythromycin all the time. Okay. Side effects, GI again. Prolonged QT, so they should avoid calcium channel blockers. Makes sense. Calcium channel blockers slow conduction, right? So with this, if you give it at the same time, prolongs the QT. HIV protease inhibitors, they should avoid taking macrolides if they're on them because they can actually arrest. Checking for anaphylaxis, but this is a drug that is safe to give to somebody that has a penicillin allergy. If they can't take penicillin, this works beautifully. Works beautifully. All right, let's talk about Zyvox treatment, VRE and MRSA. You got to know that. Zyvox is MRSA and VRE. You got to know it. It's our big gun when others fail. Check your CBC. Here's your colitis again, right? Check the shitter. Everybody gets inflammation in the bowel with antibiotics, right? Liver function. Here we go. Liver, kidney. They can go into lactic acidosis. So if we think about, our penias, we've got to check our CBC. Colitis is common. Liver functions check. No tyramine. What should we avoid them from eating? Cheese, wine, processed beer, all the good stuff, right? Anything processed meats. Don't forget about like your salami, right? Turkey too. Yep. All right. How about our cyclopeptides, daptomycin or cubicin? We use this to treat MRSA and VRE. We were using this a lot before. I don't see us use it as much. You guys might, I don't know if you, I feel like certain units get kind of, depending on who's running the unit and who's seeing the patients, kind of get like categorically, they like certain drugs. Side effects, here we go, colitis. They can actually have hypertension or hypotension. Again, CPK, we're looking at if it impairs the muscles. They can have some muscle cramps. They can go into renal failure and have some back pain. All right, so vancomycin, I'm telling you, you got to know vancomycin. If you don't get a test question from Mrs. Phillips, you're going to get a test question on boards. Okay, first line, MRSA. We have to check a vanc level. You have to check a vanc level. As the nurse, think about an SBAR. Clients start on vancomycin. We see the CVD and creatinine go up. It's day 3, 48 to 72 hours. We should be thinking, where's my peak and trough or random vanc level on this patient? Absolutely. And if it's not ordered, you better recommend it. I've seen more patients go into renal failure because of vancomycin dosing than any other drug in the ICU anyways. Ototoxicity, cranial nerve, 8, right? We could use it PO for C. diff, right? It's secondary to flagyl for C. diff. Okay, renal failure, big deal. Red man syndrome, if we give it too fast. They could be hypotensive if we give it too fast. Remember, HPTN, hypotension, HTN, hypertension. Signs and symptoms of hearing loss, it's usually permanent. Check your kidneys. Look at your urine output. Always, always, always. Flagyl, okay. Metronidazole. You guys know this from 122. When in doubt in the GI, we give what? Flagyl, right? Remember, we give it for, oh my God, what's the upper GI bug? H. pylori, thank you. Thank you, thank you, thank you. We give it for H. pylori. We give it for colitis. We give it for inflammation when they have ulcerative colitis. We give it when they have Crohn's inflammation. We give it when they have a perforated bowel. We give it when we're treating diverticulitis. We give it for C. diff, right? So think of those fungus bugungus. It's anaerobic, right? So we treat anaerobic metabolisms, remember, or bugs. Anaerobic bugs grow anywhere. They multiply anywhere. Okay. First line for the diff. Okay. Don't forget central nervous system disease. These patients can have seizures. Big deal. You guys did really good with your, on the ones I graded, you guys did really good with your drug cards. Neurologically, you have to check for seizures. They cannot drink alcohol. They might think, oh, I've been on other antibiotics before and I drank alcohol. No, no, no. They will projectile vomit sicker than they've ever been in their life. You must teach them no alcohol use. Then it can end up with a dark urine, furry tongue. Check LFTs. Check LFTs. And then your antifungals, like diflucan, nystatin, we use that a lot topically for skin, or think about topically when we did it for thrush, right? You guys gave the nystatin solutions. Well, that's actually considered a topical. We use diflucan. The other is this amphotericin B, right? You guys remember when you guys were learning your antidysrhythmics, there were certain things you couldn't take with amphotericin B. Amphotericin B used to be called amphoterrible. It makes the patients feel terrible when we give it. They called it the shake and bake. That's what patients feel like when they would take it. Okay. Shivering, amphoterrible, shivering, they would feel terrible. Almost like they got, like patients feel like when they get chemotherapy. That's how these patients feel like when they get chemotherapy 2 days later and they feel terrible. That's how these patients feel on this antimicrobial. Signs and symptoms, they can have hepatotoxosis. Okay. Renal toxic. So you got to check your liver enzymes. You've got to check your renal. They can have a low K, low calcium, low mag, low blood pressure. Everything goes down. Flu-like symptoms. When we're giving it, we have to check vitals every 15 minutes. Don't forget checking your labs. We could pre-medicate though. So think of this as like, okay, if your patient gets chemotherapy, what happens? Their electrolytes drop, calcium, potassium goes down, mag goes down, blood pressure goes down, right? So I think of this as like right down like a chemotherapeutic reaction. What do we give for those patients? Well, we give them something, an antiemetic to stop them from having nausea and vomiting. We give them Tylenol to stop the fever. We give Benadryl, the antihistamine, to swap the swelling and the pain, or Solumedrol. It decreases the reaction-like symptoms. So they're not actually having anaphylactic reaction. This is a typical reaction of the amphotericin B. Amphoterrible. So pre-medicate. How we doing? Okay, keep going. What's next? I forget. Transplants. Okay. Okay, so transplants. So 2 things we got to think about with transplants. Live donor. Okay, so this would be like, hey, I'm alive. You can have my kidney. I'm going to keep one, you take one. Okay, live donor, or cadaver, which is after cardiac or brain death. Now, this is why we have we do a brain death criteria, because if they have cardiac death, then we can't take major organs. We can take tissue, but we can't take major organs. But brain death, we can take major organs. Okay, brain death, we can take major organs. Autograft, okay, self to self. Think auto, it's mine. Okay, so one part of the body to the other. So common sense says, like, I wouldn't take out my own kidney and put my own kidney back in my body, right? So we would not do that with an organ, but tissue, yes. Heterograft, 2 different species. So this would be like if they had a baboon heart or a tissue valve transplant from another organ or different species. So that's heterograft. Allograft is same species, human to human. Okay, so this would be like, okay, I'll give you my kidney. Or isograft is identical twins. Okay, so twin to twin, identical twins. Okay, there's a couple laws here that she talks about. Uniform Anatomical Gift Act. This is laws about donation. Healthcare provider must report client and report donors. So this is why I said, when you guys are in the ICU, I don't care what your values are about organ donation and transplantation. You are required by law to report anybody that is a possible organ that meets the criteria for possible organ donor. They're absent of brainstem reflexes, right? So you guys are in the ICU, you'll see those signs up there. That doesn't mean that the patient wants it. That doesn't mean the family wants it. That doesn't mean that you want it. That doesn't mean that none of us want it. That just means that we are by law able to report that. We have to. Okay, so that's all that law means. The National Organ Transplant Act, this is a big deal. So this is like prohibits selling human organs and tissues, right? So we have criteria that says, if you come in and like, okay, you're put on the list, you're first in line to get the liver because you're the sickest, but you meet the criteria. But let's say Amber's husband's a gazillionaire and she also needs a liver. And he's like, well, that person would match my wife. I'll pay for that liver. This law prevents that. Okay, this law prevents that. Sorry, Amber, you can't buy the liver in front of me. But that's all that it does, right? It just prevents that inequitable treatment towards organ, because there's a criteria removal. So that's what that law means. And then the Uniform Determination of Death Act. This is the regulating body that regulates brain death criteria. Okay, so this is that regulates. This is how we say we're going to do the we're going to do the apnea test. We're going to do the caloric test. We're going to do all those tests. That's what this is. Okay, that's what that means. The Uniform Determination. Here's your criteria. So if we're doing organ donation, this is what the donor, the rule. So know these. I put them on here specifically. This is what we must maintain in the donor. So you're an SIC. Anybody get to take care of somebody that was brain death criteria? Yeah, it's kind of tough, huh?
Yeah, and then like as soon as they did the test, like all his vitals were like his blood pressure was good. I think at the end he was only able to get like
Yeah, everything started shut down. Sure, I understand. So look at these numbers are different than somebody that's a regular healthy patient. Okay, so if your patient is legally pronounced brain dead, they're pronounced brain dead. That doesn't mean they go right to surgery and we take the organs. They're usually in the ICU. We take care of them, especially in SIC, for 2 to 3 days. Okay, we take care of them and we harvest the organs and get them ready for transplantation, right? So we got to look at the patient's blood work, and we've got to find the match, and we've got to look at the heart and make sure the heart is suitable for. We've got to do all this testing. But in the meantime, this is what we must keep to maintain that the organs are suitable for transplantation. So MAP greater than 60 to 1, between 60 and 110, CVP 4 to 12, ejection fraction greater than 50%. Your pH, look at that. See how it's a little bit off, 7.3 to 7.5. Your PF ratio has to be greater than 300. That's similar. That's just like the other patients. Sodium less than 155, glucose less than 180. So we have to maintain those controls. Urine output, very different. It's not just 30. So 0.5 milliliters per kilogram per hour. So if I weighed 100 kilograms, that means what? 50. You better make sure I have 50 milliliters an hour of urine. So you have to know your patient's kilograms, right? And then low dose vasopressors, right? Low dose vasopressors. We don't want them on high dose vasopressors because even though that's maintaining a map, that's good. That means that we're not perfusing our organs very well, right? We're maintaining a cardiac output, but we're only perfusing those organs so much. Okay. So then when we look at transplanting, okay, heart and lung are 4 to 6 hours, right? That's not very long, right? You got to make sure that, the person, the recipient is ready to go. So literally at the time that they're going to pick up the organ, that other patient is being wheeled into OR to get them ready, right? I know it sounds crazy, but you know, when you see, if I don't know if anybody works in OR and has been privileged enough to see this, but they do come in with their like red carriages and they're like, okay, I'm here for the heart, I'm here for the lungs. And in this area, sometimes they'll copter in and out for like heart or lungs. But if it's something that we use the either the Air Force Base or the Vienna Airport, because we're not using that. So they can fly in there, they ambulance here, pick up the organ, ambulance back, and then fly back out. Okay, so there's always a plan because we only have so much time. So heart and lung, 4 to 6 hours, liver, 12 to 24, kidneys, 48 to 72. Okay, the HLA matching decreases rejection, cross matching decreases antibodies. So very important, right? We're doing so much better at matching patients, so we have a decreased resistance. So estimated length of life is usually less than 12 months to be the recipient. They have to be psychologically ready. They have to have no other serious health problems. And they must not have or severe functional disability. Okay, that's a qualification to be the recipient. Post-operatively, we have to think about vascular thrombosis. Obviously, we must think about bleeding. We're taking one organ from one patient, putting it into another. So do we clot? Are we bleeding? And then do we have anastomosis leak, which would happen with any type of surgery? We'd have to be thinking about that. So now that we've taken care of, the left side is we've taken care of who we're taking the organ from. We've kept them stable. We've taken the organ and we've within the time frame got it into the new body. Now we're taking care of the patient that actually has the organ. Okay, so the left side is getting that organ ready to go. The middle and the right side is taking care of the patient that received the organ. Okay, so graft rejection. Okay, this is how I remember this because I don't know. I just needed a mnemonic and I'm not a mnemonic person, but hyperacute, super fast. E comes before T. So hyperacute is B cell lymphocytic reaction. Acute is T cell, just alphabetical order. So hyperacute, B cell lymphocytic, this minutes to hours. It's rare because we have all this wonderful HLA matching now. Acute is T cell lymphocytic. This is days to month. Okay. This is the job of the nurse. We must catch this right away. We must pick this up right away. And then chronic, okay. This is the antibodies slowly attack the graft, organ ischemia, and the patient and the organ will die. Typically, this happens because the patient remains non-compliant. They take another medication that interferes with their auto or anti-rejection meds, or they're non-compliant, they don't take them. And then the body starts, the antibodies start to attack the organ. How do we prevent this? Okay, well, we've got to suppress the immune system. So how do we prevent these reactions? Well, you know, it's an autoimmune reaction. It's attacking something because it's foreign, right? Well, yeah, it is foreign. It's not the heart, the patient's original. It's not the kidneys. It's not the, right? So so we've got to suppress the immune system. Okay. So these calcineurin inhibitors, okay, they're most effective. Okay. One of the drug names is a cyclosporin here, or Sandoimmune. The nice thing about this drug class, I would know this, it's the most effective and there's no bone marrow suppression. So we don't have to worry about like H&H and your cells being down. Okay. But it's highly incompatible with other drugs. So that's bad, right? Because now there's so many things we can't give the patient, but it's a really effective drug and it doesn't cause bone marrow suppression. So very important. Glucocorticosteroids, you guys know that. We worry about wound healing, gastric ulcers, Cushing syndrome. They can't stop them abruptly. They have to take them with food. So we can use those. Usually we use this a little bit more acutely. Like if we start to see a reaction happening, we can use the glucocorticosteroids to shut them down. We have the anti-proliferatives. Okay, these are your cell sept medications. They do suppress the bone marrow. Remember, we were giving cell sept in myasthenia gravis. Autoimmune, right? Same thing. Autoimmune, we're shutting down the immune system. Check your CBC, LFTs, and electrolytes. And then you have your mono and polyclonal antibodies. Okay, so this is your CD3 or orthoclone C or OKT3. Here's the big thing with this. You have to worry about anaphylaxis. When you're giving these meds, you have to have epi at the bedside and be prepared to start CPR. We can pre-medicate though with Tylenol, Benadryl, and steroids. Okay, so if we're worried about anaphylaxis, we can pre-medicate with Tylenol, Benadryl, and steroids. Okay. Problems that you'll see with all immunosuppressants. Well, we leave an opportunity for opportunistic infections, right? Because now we're shutting down the immune system so we can allow the opportunistic infection. They can cause organ dysfunction, maybe malignancy, right? You always hear about these people that are on autoimmune suppressants who worry about lymphomas and things like that. They can have post-transplant diabetes and steroid problems. Stem cell transplant, let's talk about that. So autologous is patient's own, so there's no risk of reaction because there's a perfect HLA match. But allogenic is another person's cells, so we want a close HLA match. Okay, why do we do stem cell transplants? It's leukemia, multiple myeloma, aplastic anemias, lymphoma, and autoimmune. So what do we do first? We usually radiate, chemo, and then do the stem cell transplant. So we usually radiate and chemo, kill off the bad cells, and then give them back the new cells. Okay, so what are we looking for when we do this? Okay, graft versus disease, good, right? Good. Graft versus host, which is the person, bad. So when we graft the stem cell, we want them to attack the disease, not the host. Okay, watch for and treat pancytopenia. So WBCs go down, platelets go down, H&H go down, right? And I'm not going to go over this. This is pretty self-sufficient, but I wanted to. So if you have a kidney transplant, okay, what are we worried about? So post-kidney transplant, post-transplant, kidney, we're worried about infection and rejection. Okay, look at liver. Bleeding makes sense because liver makes clotting factor. Infection and rejection. Heart, infection, rejection. Dysrhythmia, of course, because our heart, and bleeding. Lungs, infection and rejection. So look at in every organ system that's being transplanted, we're worried about infection and rejection, right? So kidneys, so if I just said, put your things away and I said, let's talk this out. Kidneys, you'd be worried about fleet, right? Because they regulate fleet. You'd be worried about urine output, daily weights, right? BUN, creatinine, GFR. How do you know that? Well, look at your labs. Look at your urine output, okay? The number one way to identify if the body is rejecting the organ is to biopsy in every case. Know that. Know that. It's the only way to find out for sure that the body is rejecting the organ. Okay, so liver. Guess what? We got to worry about bleeding. Why? Liver makes clotting factors. What are we looking at? ALT, AST, bilirubin, blah, 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 blah. You guys all know that, right? We're looking for signs and symptoms of bleeding. Biopsy for rejection. Heart. Okay, so here's the thing they have to think about with the heart and the lungs. That we have no autonomic nervous system response. So if your patient goes into septic shock and your patient has a cardiac heart transplant, are they going to become tachycardic? No, because those nerves were cut in the transplant. So we have that no ability to auto-regulate. So that's very important to understand in pulmonary and cardiac instances, right? Because I can't like have a good cough reflex, right? I've lost that autonomic nervous system that those reflexes. Okay. So atropine doesn't work. They're unable to respond to hypovolemia. So all your shocks, they're unable to respond. Okay. So we're looking for weight gain, malaise, edema, AFib. If we're worried about rejection, we're looking for dysrhythmias, right? So not hard, just think about it. Just think about what the organ system does, right? And then lungs, okay, infection, rejection, airway clearance, and gas exchange is a problem, okay, because of the nerves that were cut. So what's going to be wrong if they reject? Shortness of breath, hypoxia. Okay, infiltrates, infection, position on the non-operative side. All right, you hanging in there? I know it's a lot today. Let's do shock and then I'll get you guys out of here, okay? So shock, okay? Do you guys need a break or you just power through it? Power through it, okay, me too. So let's think about the 4 phases of any type of shock. So you're not gonna come up to me on like Wednesday and be like, okay, if my patient's in anaphylactic shock, are they in the progressive phase? Maybe. Every single type of shock can go through all 4 of these phases. Remember we talked about that with renal before. Doesn't matter what the injury is, they can go through all 4 phases of acute kidney injury. Same thing here. So initial, we have a decreased cardiac output, elevated heart rate and respiratory rate because the injuries just happened. Compensatory, now the body tries to help itself. So we have angioconstriction, right? And we're able to increase our cardiac output because our first responders kick in. Okay, but after a while, we can only respond for so much. So we start to get into an acidotic state. Our potassium goes up, we start to end up hypoxic, and then we progress into the progressive phase, which means our body can no longer compensate. And if we don't intervene here, the patient's gonna die because they're gonna end up in a refractory with MOTS. Okay, so progressive is compensatory mechanisms fail. We go to lactic acidosis, the blood pressure and cardiac output drop again because we're no longer able to compensate. We have vascular permeability and everything leaks. Refractory, it's bad. MODS, severe, die, no recovery. Okay, so we got to prevent them from there. So I did this in a linear pattern. Okay, so hypovolemic shock. Remember, this is the pool. The pool's empty, right? The vascular space is empty. So they're bleeding. Fluid has shifted out of the vascular space. The pool is empty. So what are your signs and symptoms? Well, look at this. Urine output's going to be down, cardiac output, cardiac index, stroke volume, blood pressure, down. If the volume's low, your CVP and your wedge are down, right? Because those are indicators of volume. So those are going to be low. Your oxygen level's down. Lactic acid's up. We're in an acidotic state. Potassium's up. Acidotic state. Okay. pH down. You're in an acidotic state. PaCO2 up. Acidosis. Your responders, right? So what happens to your first responders? Heart rate goes up. Your respiratory rate's going to go up. And your SVR goes up because it's responding. Your afterload is high. You better know the numbers. Okay, I didn't put them all back on here. You already know them. So fix me. Well, fix the cause, right? I can give blood and fluid all day long, but if I don't stop the bleeding, then my patient's still sick. So fix the cause. Take them to OR, stop the bleeding, stop the fluid shifts. Okay, give fluid, give isotonic. If we're dry in the vascular space, we want it in the vascular space, right? Give blood if we need to give blood. Okay, do we need to, so if I stop the bleed, I add fluid, and I don't get any better, do I need a vasopressor? Maybe. Leave a fed or leave them dead. Leave a fed or leave them dead in hypovolemic shock. Okay. And then how do I know I'm better? Well, look at your eyes and nose. Am I peeing? What was my problem? Was my MAP 50? Is it 65 now? Right? Am I perfusing my organs? Do I have good capillary refill? Okay. Look at your hemodynamics. Look at your weight. Look at your level of consciousness. What's my brain doing? Am I perfusing my brain? Yes. You can, but it would be 4th stage. So it would be fix the problem, give the fluid, give a pressor, give an nitro. Because what's the problem really? It's the pool. I hope so. If not, we missed something. We can't. Yeah. It's rare. Like I think of a lot of hypovolemic shocks I've taken care of in SIC. A lot of them are volume depleted because they're bleeding out somewhere. It's rare that I've given a nitro. But if you have somebody that maybe has hypovolemic shock and they already have heart failure or something, they might respond better to a nitro, but it's not first on the list. Yeah, sure. Okay, so then let's talk about cardiogenic shock, right? So this is a pump problem. So why? Myopathy, cardiac myopathy, MI, number 1 reason. So your signs and symptoms, level of consciousness change, cardiac output, cardiac index, blood pressure, urine output, it's going to be down. Okay. What's going to happen to your preload? Your CVP and your wedge goes up, right? The pump stopped, it's backing up. So now we have a lot of volume. We have a lot of preload, right? Okay. If that fluid's backing up around the heart and the lungs, chest pain, crackle, shortness of breath, right? They might have edema, S3, S4. Okay. What happens to your first responders? Well, your heart rate goes up, your SVR goes up, your afterload's up, your respiratory rate's up, all the first responders kick in, okay? So fix me, treat the cause, right? I got to fix the pump. So if they're having an MI, we got to get them at the cath lab. You know, we've got to treat that, okay? Your problem's the pump. So your first line, once you know it's cardiogenic shock, is going to be to give that inotro. Get the pump working again. I'm in fluid overload. Now I diurese and I vasodilate if needed, okay? If hemodynamically stable. This is where students get messed up in their mind. They're like, well, you said that if any patient comes in and they're okay, we talked to our ER girls, right? Anybody that comes in that's in any type of shock initially gets fluid and probably vasopressors. But once we identify it's cardiogenic shock, we got to fix the pump. So we flip to an inotrope, we get the pump working, we allow that we fix the MI or treat the MI, and then we get rid of the fluids to help the pump not have to pump into fluids, and we vasodilate afterwards to decrease afterload. Don't forget about even using a balloon pump, right? Balloon pump reduces afterload. Okay, how do we know? Don't go crazy. What's our level of consciousness? What's my urine output? What's my cardiac output? How do you know that they're better? Don't memorize it crazy. Don't get crazy and memorize. You already know the answer. What was the problem initially? Yes. Yep. You got a gas exchange problem and you've got a organ failure problem. No, you're usually acidotic. I want you to think about I want you to think about every one of these patients in an acidotic state. Okay. When the patients are sick, they're usually acidotic. When they're really, really sick in the ICU, they're usually acidotic. Okay. So I have green for our distributive and anaphylactic shock because these are pipe problems, right? Okay. This is just like neurogenic shock, right? Neurogenic shock is a type of distributive shock where everything's wide open. Blood vessels go wide open. We vasodilate. We lose our autonomic nervous system function. So anaphylactic shock, what's the cause? Well, they've had an immune reaction to something like blood, a medication, and we've had an antigen reaction where we have our mast cells released. So what do they look like? Where they're short of breath, angioedema, urticaria, blood pressure's down, cardiac output, cardiac index, CVP, atrial pressure down, heart rate goes back up, okay? But here's the thing that makes this different from the other shocks. Your SVR and your wedge are both down. Your CVP is down because why? We vasodilated, right? So now your ability, because you lost your autonomic nervous system, your ability for your arterioles to compensate, it's not there. So I can't clamp down, right? So now my CVP and my SVR are down, right? I've got a decreased preload and a decreased afterload. So fix me, stop the offending agent. Please don't go run in with epi and give them epi as the blood is still running, right? Stop the offending agent, stop the antimicrobial, stop the blood, stop whatever, stop the IV dye, okay? And airway, we got to give epinephrine. Think about the airway. We've got to intubate the patient maybe. If they have a lot of angioedema, think airway, oxygen, epinephrine, and fill the veins back up, okay? Give fluid, okay? We could give steroids for inflammation. We can give Benadryl, but that's not going to fix the reaction, right? That's not going to fix the reaction. So we got to stop the offending agent, provide an airway, give epinephrine. Okay, so let's talk about septic shock. Okay, so same thing. It's a pipe problem. 2 or more system infections, 1 organ dysfunction. Usually it's heart, cardiac, or lungs. So pipe problem, CVP down, cardiac output, cardiac index, cardiac stroke volume, blood pressure down. Okay, heart rate goes up. These patients have a wide pulse pressure initially because remember, unlike anaphylactic shock where they go into it super fast, septic shock, they start that inflammatory cycle. Do you guys remember that? It's like infection, SIRS. So initially their cardiac output and their cardiac index go up. Okay, their blood pressure goes up and we have a wide pulse pressure because they're compensating for a long time. And then eventually they're like, hey, listen, I can't compensate anymore. I need your help, right? And then it drops. Okay, so fix me, okay? Well, start your broad spectrum antibiotics. Don't forget to culture first, culture everything, right? Culture, send it to the lab, start your broad spectrum antibiotics, give fluid. Remember I said hit them with 3 liters right away. I don't care if they have renal failure. I don't care if they have heart failure. They need fluid. Everything's leaking out of the vascular space. We can take the fluid off later, but if I don't perfuse my organs, they're going to die. So we give a lot of fluid, we culture, we start our broad spectrum antimicrobials, and then we start vasopressors. Norepinephrine, leave a fed or leave them dead. Do we need steroids? Maybe. Okay. These patients can go into MODS, so they can have 2 or more organs failures or dysfunction. So GI, like we talked about, you guys know what happens when they have a GI failure, obstruction, ileus, right? Liver. So think about what signs and symptoms you would see with each organ system and what it would look like it was failing. You can have a hematological immune response. If they're in MODS, we usually give fluids, vasoactive drugs to treat the MODS. Maybe put them on a ventilator, give some blood, give some oxygen. They're usually not doing well. They're circling the drain, right? Unfortunately, just is what it is. DIC. These patients get into such this inflammatory cycle, we start a clotting cascade, right? And we clot. We use up all of our clotting factor. And after we use up all of our clotting factor, what happens? We bleed, right? So guess what? My PTINR goes up. My PTT goes up. My platelets go down. Okay, I've used up all my, I've used up all my clotting factor. My fibrinogen, what happens to fibrinogen? Goes down, right? I used it all. I used my clotting factor. What happens to my FSP and my FDP? Goes up, right? Because those are your clotting, those are the end product of using the clotting factor. Okay, so we could give platelets, we can give fresh frozen plasma, we can give vitamin K. Okay, we give IV fluids, we might give inotropes, but we might give heparin, right? Like, why would you give heparin? Well, heparin stops the clotting cascade. So it stops us from clotting so that we allow fibrinogen to actually work like it's supposed to. We don't use it all up. Okay. How do I know that we're better? Well, you'll start to see the blood levels reverse, but the most specific indicator is fibrinogen will go up. You're like, oh, thank God I have some clotting factor left over. You'll see them reverse. So you'll see your PTINR go down, your PTT will go down, your platelets will go back up, your FSP and your FDP will go back down, but your fibrinogen will go up, and that's the most specific indicator. No, just know that it'll go up. Okay, so then let's talk about these meds. I'm going to buzz these really quickly because you guys know these. Okay, so we started doing drug cards with you guys and started doing Swift River with you guys from Jump Street, right? You guys remember Swift River and the drug cards in 110, right? You don't remember, you've blocked it out. And we started them to the other students halfway through the program because we're like, we got to make sure you guys know your meds, right? I'm completely impressed because last year, this time, and fall, and this year, after we've implemented these, the national average on the pharmacology scores on ATI are like 58, 59%. You guys were 78% collectively as a group. You guys know your meds. Don't judge yourself. Like in the fall, we were 76%. The state average is like 82%. The state average is 62%. You guys are 78% on pharmacology. So I know you looked at all those drug cards and you're like, oh my God, if they give me one more damn drug card, if they ask me one more question about it, you're ready for boards pharmacologically. I promise you that. So you know these meds. If I said to you right now, why do we use Dobutrex? Somebody tell me why we use it. Enhances contractility, right? He was like, no. What? It's an inotrope. Like, oh my God, I just gave you a pep talk. It's an inotrope, right? Okay, and in terms, so if I said to you, what type of shock would you expect to give Dobutrex to? First line? Cardiogenic, because it's a pump problem. So we got to get that pump working, right? How do you know that it's working? How do you know Dobutrex is working? Cardiac output, cardiac index, blood pressure, right? What are you treating? What are you giving it for? Okay, how do you know it's working? Okay. Let's see. Dopamine, same idea. It has alpha beta. Remember, low dose, we use it to perfuse the kidneys. Moderate doses is moderate to high doses is inotropic effect, but high doses is vasoactive activity for dopamine. St. Joe's loves it. I don't see us use it a lot of other places. Epinephrine. Why do we use epi? First line. Anaphylactic shock. Why else could I use it? Cardiac arrest. Anaphylaxis. What if my patient's hypotensive? Would it help? Yeah, it's a vasopressor, right? So it works on alpha, beta, beta. Okay. First line for anaphylactic shock. Okay. We use it in dosing all the time too for ACLS. When we were talking about in a team and you guys were talking about pushing epinephrine, we push it all the time. Levofed, norepinephrine. What does it do? Where does it work? Alpha and beta 1. So it's not going to help your lungs. So don't go running with norepinephrine and anaphylactic shock. Doesn't work, right? So it's going to increase contractility and increase the heart rate. It's going to have vasoconstrict. It's our first line drug for shock in general. Okay, so if I talk about hypovolemic shock and septic shock, you're going to say Levofed or leave them dead, right? First line vasopressor for hypovolemic shock, first line vasopressor for septic shock. Okay. Neosynephrine, it works beautifully. We use it a lot in our younger patients because it only works on alpha. So it's only going to vasoconstrict. It does nothing for the lungs. It does nothing for the heart rate. But for somebody that's extremely tachycardic, this drug might work well for them. We have a lot of young patients in the ICU and SIC, right? Because we have a lot of young patients out there. But this drug works really, really well. So there's just a review of alpha beta. Okay. Don't forget Regitine. If you have a vasoactive medication that is infiltrates, you need to inject with Regitine. Vasodilators, you have nitroprusside. Okay, these are the ones that dilate. So everything else we talked about talks about vasoconstricting and improving cardiac output. These patients have a high blood pressure, or the heart is failing and we need to dilate the afterload so the heart doesn't have to work as hard. Okay, so nitroprusside decreases afterload or SVR. Used in hypertensive emergency, you need an A-line because you could drop the blood pressure too quickly, right? And then don't forget about that cyanide toxicity. So we have to check that thiocyanide level. Tridal or nitroglycerin, it's nice because it vasodilates. So we love this in cardiogenic shock, especially if the reason's an MI, right? Because it's going to vasodilate and it's going to cause, it's going to increase perfusion to the cardiac tissue because it's going to dilate those coronary arteries, decreases afterload, decreases preload. So you don't have as much fluid going into the heart and you don't have as much pressure to push a pump against. You have to check blood pressure. Don't forget about using tridal tubing, right? The regular tubing will absorb the medication, so it can't be utilized. So they need to use the specific tridal tubing for this. Big side effect, headache. Guess what? Don't care. I'll give you some Tylenol, but you still need the nitro. Okay. The headache won't kill you, but the MI will, right? So we got to make sure we treat the headache. Okay. Questions?